Every single person that is involved in providing infusion therapy is part of the revenue cycle. So if you're in sales, if you're a delivery person, if you're a warehouse person, if you're a tech, pharmacist, wherever, you are all part of the revenue cycle, every single one. And so what that means is we all have an obligation to the financial health of our business. In order to be able to do the number one thing which we do, which is take care of patients, we have to have cash. We have to be able to get paid for our services. So one of those critical foundational things is we're all part of it. And the other thing is that I really want you all to come away from this with the understanding that the reimbursement and revenue cycle group should be your BFFs. There should be a partnership within your organization between sales and reimbursement. It's very collaborative. There's a lot of opportunities for revenue cycle and reimbursement folks to partner with you. And some of the most fun that I've had as a revenue cycle person has been partnering with our salespeople, going into accounts. And yeah, it might be because the account isn't paying for our services and we need to have a difficult conversation, but we've had a lot of success with those partnerships. So, if you don't know who your billing collection director of revenue cycle is in your organization, definitely after this, hopefully you will reach out and find out who that person are or that team is and really look for those opportunities. Another one of those foundational things is one of the most critical things that we can all do is ensure we have a path to payment for every service we provide. And I'll be touching on that throughout, but the revenue cycle starts all the way back when we get the contract from the payer, when we take the patient on service, when we do the benefit verification. It doesn't start when we send the claim out or when we, bill for our services. It starts all the way back. And it really takes all of the pieces falling in line throughout that entire process to ensure that we get paid for our services. There's only so much we can do on the billing and collection side once those initial pieces have been done. So if we didn't get an authorization, for example, or we took the patient on service hoping that we would get the clinical documentation that we needed in order for us to be able to provide that drug or get paid, and we weren't successful, there's only so many things that we can do once those services have been provided and those charges have been created to get paid. And ideally, that should not be the patient. So sometimes I hear, especially when I was doing some consulting, companies would be like, if Medicare doesn't pay or if Aetna doesn't pay, we'll just bill. The patient knows they're going to be responsible. Well, patients are not consistent and they're not reliable sources of payment. Patients typically, and I don't have an exact statistic for you, but patients don't really like to pay their medical bills, to be honest with you. And so we don't want to rely on patients to pay for services that we should be able to secure an alternate primary source of payment from. So one of the things that's critical is for everyone to understand what are we looking at to assess the financial health of our business. So these are just 5 key performance indicators or KPIs that we look at. Every business is different. You may look at one of these, you may look at all of them. The clean claim rate is really how well are you doing getting claims out the door that require no additional intervention and are paid successfully the first time. So I sent the claim to Aetna, for example. They paid it 100% or whatever we expected them to pay, and I did not require any additional action. So those typically we want to see in the high 90s, 90%, 95%, 98%, somewhere in that high range. Your DSO is your days sales outstanding, and that is essentially how long does it take to get paid for a claim or a charge or a service you provide. We don't want to wait 90 days, 120 days, 180 days to get paid. We don't want that to be our average. We want our average to be, again, individualized for your business, somewhere between hopefully 30 and 60 days. What does that tell us? That tells us that we've got a good cash flow because we're getting our claims out and we're getting paid quickly. And sometimes we look at these by payer, by therapy type. For example, if you're maybe assigned to a payer account as a salesperson, you should know or have a sense of this, of your financial health for that payer. And that can be different conversations that you have with the payers on, if you're only seeing a 60% collection rate or a 50%, you have a problem. There's issues that you need to work on with that payer so that you can get paid at a higher rate for your services. Kind of getting back to what I talked about at the beginning of path to payment and securing that path to payment. So this slide is what I like to call the happy path. This is what we want for all of our claims. We want all of our front-end processes to work beautifully. We verified the benefits. We knew that it was covered. We got the auth. We did a test claim if we have a RX plan or an NCPDP payer involved. And we've done all of our front-end work. We have a contract. Beautiful. They get the patient receives our therapy. We bill for it. We get a payment. Beautiful. Nobody else had to touch it. Wonderful. So that's what we want, but this is usually what it looks like, or in a lot of cases. So we did all the front-end work. We did all of that beautifully still, and we billed for it, and then we got a claim rejection. Okay, so somebody had to touch it because, we didn't have the date of birth entered right, or we didn't have our provider number. And then the claim finally the payer accepted our claim, and then we got a denial because we didn't have, something filled in right. And then we had to call them, they reprocess. Then they paid us, but actually they paid us short. So we thought they were gonna pay us, $1,500, they paid us $40. Then we had to call them again and say, please, you need to pay us. So this is just a concept of, I think sometimes it's not always obvious behind the scenes what all goes on sometimes to end up actually being able to get paid. And for infusion, it does tend to look like this model more than the happy path. There's a lot of complexity in our benefit, patients' benefit types or benefit scenarios that we see for home infusion. So one of our most common is major medical, and that's probably the most quote-unquote easy, although I'll say that it tends to get, or it has been getting more complex recently. We also have a pharmacy benefit that we bill to at times, depending on, again, does the patient have a Part D? Do they have a Medicaid plan that we have to bill to the Medicaid PBM? All depending on that individual patient. Sometimes we end up having to bill to the DME benefit. So for some coverages, home infusion is actually covered under the DME benefit. So you think about Medicare Part B, it's technically covered under DME. Some of our government plans, even when we're verifying benefits, we need to verify benefits for DME because that's how the service is covered under. And then sometimes we see the nursing, in some cases, covered under the home health benefit. So the patient may have a home health benefit that covers the nursing, and that has a cap of 20 visits a year or something like that. Then our home infusion is going to go to the major medical benefit, and that might be a different coverage scenario where the patient has a different out-of-pocket. So they might have a copay for the nurse, and then they have 80/20 for the home infusion services. There's a lot of times where it is actually a combo of multiple of these benefit types. In home infusion, and I've always said this, and I've had this backed up, is probably one of the most, if not the most complex billing requirements than any healthcare provider. We have a ton of complexity. We have a lot of different codes that we bill, and we have a lot of individual payer-specific guidelines that lack standardization. So typically, what we bill for from a coding perspective is we bill for the drug, which is usually a J code. There can be some exceptions. We bill our per diem codes, which are typically our S codes. And those were created out of a initiative by NHIA, I think in 2005. It's almost been 20 years when we got the S codes. Before that, it was really the wild, wild west. There was no standardization at all. But some payers did not adopt the per diem codes. And so then we also have our kit codes. So those are codes like A4221, A4222. There are supply kit codes. So if we're billing to Medicare, we bill kit codes. So instead of billing a per diem, we bill a code for catheter maintenance supplies, and we bill a code for pump administration supplies. And then we also bill pump codes, or equipment codes, and those are typically E codes. And those, again, it's gonna be dependent on the payer. In a very generalized way, commercial payers accept per diem codes, S codes. Government payers accept kit codes. But it's really important to know every single payer, you have to understand your contract and how to bill. But I do want to bring your attention to the NHIA standard per diem definition, which you can get on the nhia.org page. It is an extremely helpful tool, and it really outlines what the per diems should include and why the per diem wasn't created in the first place, and really provides for payers especially the understanding of why we have a standard per diem set for home infusion. And so I have seen success working with payers in utilizing that NHIA standard to get the payer to adopt that standard versus whatever craziness that they've come up with. My last group of topics is just other considerations. So these are things you have to think about. Again, this is when you're taking patients on service, when you're evaluating patients to come on board with you, but also in the contracting phase. What are you contracted with from a site of care? Is it an AIS? Is it an AIC? Is a patient in a nursing home? Are they in a hospice? Are they maybe in a jail? We do see that as well. Are they getting services from a end-stage renal disease facility? Different sites of service can result in different types of benefits. And depending on, again, how you're contracted, you may not be contracted for AIS, or that may require a different billing. So you need to make sure that you're clear on where the patient's getting service and to make sure that you're contracted for that, and you understand what the patient's benefits are going to be for that. Payers also have specific medical policies at times. So IVIG, usually payers have a posted or published policy on IVIG. Like I said, Lyme disease are probably two of the most common, but there's also other therapies out there, and usually those are published on the payer websites. So that's something else to also, A, have an awareness of, but also B, keep an eye on. If there's new policies being published, you want to have awareness for those. Because a lot of times if the patients do not fall within the coverage guidelines in that policy, they will, even if you get off in some cases, you may get denied. Method of administration can come into play sometimes. So if you're providing an IM injection or a different type of injection, like a sub-Q injection, it may not be covered with the same benefit, or it may need to go through a different type of benefit than if you're providing IV. And then just back to the payer contracting comment, I know I've been harping on this a lot, but it really does start with our contracts and that partnership between reimbursement and revenue cycle, and our sales teams and our intake team within our organization. If we get it right with the contract and we know exactly how to set that up, we know exactly what the payer is going to require, that's going to help us with our clean claim rate. That should help us with our DSO and our other KPIs that I mentioned. So it really starts all the way back there and then continues, again, through the intake and billing process.